So this is a post-transplant patient. The protocol is to first make a coronary angiogram, and if there is a graft rejection and if there is a diffuse vasculopathy, then one would consider an IVUS, so CT-FFR, and a drug-coated balloon. So here we have used a Mullin sheath. This is basically to look at all the pressures, RA, RV and pulmonary artery, and then do a bioptome. So this is a Mullin sheath, or it's in the RV or the right guiding catheter. This is a bioptome. You see how the bioptome is to use the biopsy, and you can see the opening of the bioptome, so that you can take a tissue piece either from the septum or from the posterior wall of the right ventricle to look for rejection. This is done 3 weeks after a heart transplant, and it's also done at every year along with a coronary angiogram. So this is a bioptome, and that's how my colleague is just pulling it back, and here you can see the bioptome. It's the opening. You pick up the piece of the tissue and then you eventually close it and then remove to look for the analysis of the tissue. So you need to do a biopsy analysis, and this is analyzed by the International Society of Heart and Lung Transplant. So there's a grading of the biopsy, and it's a cell-mediated rejection or antibody-mediated rejection, and subsequently one can go for the various types of immunoglobulins. So there's a grading of the rejection, grade 1, 2 and 3 and above, and in grade 1 you leave it on medical therapy, otherwise a pulse steroid, and later on the immunoglobulins or one of the everolimus or tacrolimus or other kind of immunosuppression has to be given to the patient. This is after the analysis of the biopsy report. So this is a grade 2 rejection where you see the lymphocytes, and you see the grade 2 rejection where this patient will need either a steroid pulse therapy, or they may even need everolimus or tacrolimus or other kind of immunosuppression. It's very important to detect early grade 1, grade 2, because later on you need plasmapheresis or you need immunoglobulins, which are expensive, and one may also need high levels of immunosuppression, and then the morbidity and the mortality increases, and best is therefore with a biopsy to detect early rejection.